All right, we are at a minute past the hour. Hello, everyone. Welcome to today's Present Approaches to Testing webinar on cytology specimen utilization, a proven approach to genetic testing. I'm Dr. Linda Hassatri, the director of the Molecular Technologies Laboratory and a consultant within the Division of Laboratory Genetics and Genomics at Mayo Clinic in Rochester, Minnesota. And I have the pleasure of introducing our speakers. So our presenters today are Dr. Yingsun Lo, a consultant in the divisions of both anatomic pathology and laboratory genetics and genomics, and an assistant professor of laboratory medicine and pathology, also here at Mayo Clinic in Rochester, as well as Katie Bartholet, a cytology specialist, who likewise is at Mayo Clinic in Rochester. Now, before we begin, just a couple of reminders. First, there will be a question and answer session at the end of the program. You can submit your questions online via the Q&A icon on Zoom. So that would be at the bottom of your Zoom panel. Please only use the chat function for any technical issues. And again, submit questions using that Q&A module. Secondly, today's program is also being recorded and will be posted to our website in a few weeks. And with that, I'll now turn things over to our presenters.
Hi, thank you, Dr. Hassatri. So I'm Dr. Yingchen Lo. I'm a pathologist at Mayo Clinic. So I do anatomical pathology, specializing in thoracic pathology. I also do molecular pathology, specializing in solid tumor molecular testing. So today, welcome everyone to join us. We are going to talk about the cytology specimen utilization, and which is a proven approach to many of the genetic sequencing. Next slide. So I have no disclosure about financial or off-label use in this particular webinar. Next slide. So some of the learning objectives we are going to cover about today. So first one is to recognize the advantages of cytology specimens over traditional tissue biopsies. The second one is to explain the best practice in specimen collection. The third one is to define how genetic sequencing has expanded the use of cytology specimens, including smears, for comprehensive genomic profiling. Next slide. So first, the background is we are in the era of elevating molecular diagnosis, because molecular testing is start to become of such important role in cancer care, not only as a research project or some like looking for some clinical trial. Now, molecular testing has been incorporated into standard of care of multiple cancer type. So molecular testing is a must-do thing for daily clinical cancer care. And genetic or molecular testing now can pinpoint the biomarkers in tumor cells associated with prognosis and targeted therapy, promoting individualized treatment for for cancer patients. That's why it's of super important clinical importance. Next slide. So how to do those molecular testing is that now we know we have to test more and more markers compared to we used to be. So the idea of testing single genes is no longer that able to fit the current need. So that's why more and more tests now we are incorporate multiple targets in the same panel. So that's how we call the comprehensive genomic profiling. Not just look at single genes, we are setting a wider net to cover more comprehensively. And the concept of comprehensive genomic profiling, we use the technology, most commonly is NGS. NGS is next generation sequencing, can let us sequencing a much broader area of the genome and look at multiple targets at the same time. So the ability of those advanced genetic sequencing to identify molecular biomarkers in tumor cells support the development of CGP to examine hundreds of genes for mutations and gene fusions for diagnostic, prognosis, and therapeutic clinical utility. Next slide. On the other hand, on the clinician side, more and more those minimally invasive procedures are more adopted in their clinical practice. So many of us are pathologists or laboratory persons. We deal with sample. But whatever sample comes from the clinician or proceduralist who perform the procedure. We deal with surgical specimens, which are normally bigger. But a lot of the patients, the diagnostic materials are based on biopsy. Compared to open biopsy, more and more those minimally invasive procedures are performed. The common examples are bronchoscopy, colonoscopy, and endoscopy. The clinician use those like tubes to go in deep into the patient to get a little bit diagnostic material. The benefit of those minimally invasive procedure is great for clinician because they pose much less risk for the patients, minimally invasive and much fewer complications. So clinicians much like those rather than open biopsies. However, at the same time, when they do the bronchoscope or colonoscope or endoscope to look at the lesion, they can also do sampling at the same time during those minimally invasive procedure, such as endobronchial ultrasound-guided transbronchial biopsy or fine needle aspirations. For patients with cancer, many times those lesions are really deep in the organ, and those minimally invasive procedures are the only way they can get to the lesion. And not always they can do a biopsy. Many times they can only do a cytology specimen, use FNA and smears, and those offer an alternative for patient procedures. Next slide. So the challenging is here. Now, the biopsies or cytology specimen they obtain from the minimally invasive procedures are pretty small. So gathering specimen for enough cells to complete the necessary genetic testing is not always possible. We know those small biopsy, especially those cytology procedure, give us very small tissue. First, the anatomical pathology or cytopathologists need to make a diagnosis based on those specimens. So they may use several unstained slides to stain for different markers to help them make the diagnosis. Then whatever left are many times insufficient material to do the next step genetic testing. Multiple studies show that molecular testing from the needle biopsy specimen for non-small cell lung cancer it's very unsatisfied. Like up to like 23 to 40% of the time, the patient does not have sufficient material to do molecular testing based on the biopsy specimen. So that's a big challenge in there because of the nature of a minimally invasive procedure, get very small tissue. Next slide. So that's the dilemma. So on the oncologist side, we now need more and more targets be tested. Look at the NCCN guidance, the newest, the current guidance for non-small cell lung cancer. For advanced or metastatic disease, after establishing histology diagnosis, the molecular tests including EGFR, KRAS, RAS, BRAF, NTRK, MET exon 14, RET, ERBB2, NRG1, HER2 IHC, PD-L1 IHCs, those are at least like 10, 15 markers. Those are must tested in non-squamous lung cancer. Even the squamous cell carcinomas, those are also considered to do so. How, on the other hand, the specimen from those minimally invasive procedures are really small. So our laboratory got stuck in the middle, right? Because more and more markers are required to be tested, but we got smaller and smaller tissue. And after diagnosis, how much tissue we left on the tissue block that we can cut into it and do more testing. So that's why considering the cytology specimens, especially the direct smears, become a very like a treasure box for us because those materials are not in the block. So if we say we get the best block to test and we cut into the block, there's not much material left. But look at the smear. There may be actually a lot of the tumor cells presented on the smears. So that's something that we can explore and actually test it and do it and they can actually help a lot of those patients. Remember, like about a third of the patient could not get molecular tested done, which is a very unmet need that we need to tackle. So many times in the past, like additional sampling may be arranged to get more samples to do testing. But actually, if we consider using those cytology slides, actually we can rescue a lot of those patients to have proper molecular testing done rather than arrange another invasive biopsy to get more tissue. Next slide. So I will hand it over to Katie to talk about the cytology preparations.
Hello, thanks, Dr. Lowe. So I'll be covering the actual cytology portion. So to start off with, what types of specimens do we consider, adequate for cytology testing for NGS? Normally, we consider FNA smears, touch preps, cytology that is from liquid-based cytology preparations like ThinPrep and SurePath. Generally, these are stained with stains like the Papa-Nicolau stain, the Diff-Quick stain, and occasionally we'll even see H&E stained cytology specimens. All of that is accepted. We can see them from all over the body, and any body site is usually going to work great for NGS testing as long as we have sufficient material. And next. So one of the benefits of using cytology over traditional tissue is that when we're cutting into the block, such as a cell block, we're actually cutting through the nuclei as well. So we end up with sometimes in non-complete tumor DNA. And therefore, the nice thing about smears is that all of the cells are complete cells spread across the sides. This allows us to actually work with less material for the procedure because we actually get a lot of full DNA and RNA from that preparation method. Next slide. So one of the benefits of having our cytology specimens are that they are actually usually using alcohol-based fixation. That actually leads to better DNA and RNA integrity. Again, this allows us to use less material to get a really nice concentration of DNA and RNA from the different extractions. And formalin is a great fixative, but it is a little bit more harsh on the DNA and RNA. So it is one thing that we have seen actually really benefit in our extraction methods. Next slide. So like Dr. Lowe mentioned, one of the challenges of getting tissue samples sometimes from these hard to reach locations are that we just can't reach them without going through an endoscopy procedure. So a lot of times we are seeing that, the tiny tissue samples that we're getting from these needles are kind of too small to do all the testing that we want to for our patients. So allowing us to have options is a really big benefit for cytology. We'll be able to use the FFPE tissue for the histologic and immunohistochemistry workup while using the cytology smears for our molecular testing. Next slide. Hand it back over to Dr. Lowe. You're on mute, Dr. Lowe.
Oh, thank you, Katie. Yeah. So when we talk about cytology specimen, I oftentimes receive a question is that what do you mean by cytology specimen? So we know like cell blocks, those are kind of like cytology specimen, but they are made into FFPEs. So in our discussions or in our traditionally, we count those cell block FFPEs as FFPE, just like tissue biopsy, like tissue block. When we say cytology specimen here, we actually mean for those direct smears. It could be a PEP or diff-quick smears. So as Katie mentions, those tend to have like more the cell integrity is better. So actually, in multiple societies, including AMP and CAP, actually review the literature and showing those smears are actually pretty good materials that can be used for proper molecular testing. As a molecular lab, we kind of the tradition is that the pathology make diagnosis on the FFPE slide, and then we cut into the block deeper to get more material to do molecular testing. And we kind of save the smears as the diagnostic material and not touching them. So that's kind of the traditional thinking process for molecular laboratory to just get a block, cut into the block, and test like those new materials. But in fact, if we don't have much tissue in the block, but the cytology smears actually provide a much more better cells quality. They are actually a good resources being shown in the multiple society suggestion to use them. So the evolution of those targeted immunotherapy combined with the recognition of use of the cytology specimen when nothing else is available actually push us to want to use the cytology specimen, the smears, on our assays. So, but it's not like, oh, we can just use the smears directly to any assays. We have to validate them first because most of the tests initially were only validated for FFPE specimen. So at Mayo Clinic, our laboratory spent a lot of time and resources to validate the cytology smears on almost all our molecular tests. Depends on big panel or small panel, there's a different criteria we use to validate those assays. But after going through a very thorough validation process, we feel confident that all the smears are capable of produce similar result, actually not inferior result compared to FFPE in almost all our NGS assays. So by 2020, the majority of our NGS cancer panels were validated to accept cytology specimens. This has opened the door for us to rescue many of those patients able to yield very valuable molecular testing result. Next slide. So let's look at some data to see how we improve the confidence and enhance the utilization of those cytology specimens. So after we validate them, we start to use those cytology specimens to do the molecular testing. So when we receive a specimen, if it's an in-house specimen, we actually, if it's a cytologist case, we actually get all the materials, including the stain slide, the unstained slide, the block, including the FFPE slides, and the smear slide, and we evaluate everything. If the FFPE cell block or FFPE tissue biopsy have good enough material, we prioritize use the FFPE specimen. But if the FFPE specimen is kind of like borderline or inadequate, we look at the smears to see if the smears actually better. If that's the case, then we use the smears to run our testing. Throughout those couple of years of experience, we found that actually we use about 18% of our case, we actually utilize the cytology specimens. Next slide. So this is a study that we presented a couple of years ago in one of the ASCAP meetings, showing our experience of utilizing cytology specimens. So first, in that 6 months period of time, that those cases that we performed the Mayo Complete Solid Tumor Panel, MCSTP, which is our largest comprehensive genotypic panel, there are 975 cases tested through this panel. Cytology slides were utilized actually for about 29% of the cases in our institution compared to 2% of the cases from external institutions. Because we know at Mayo Clinic, we not only serve our internal in-house laboratory, but as a reference lab that accept specimens from external institutions. Look at the table on the right. Those large panel molecular testing, a good amount of them, probably more than half of them, is lung, and the next one is GI, and with some others like a smaller portion. So lung is the predominant tissue type. And we test the overall, we test about 73% of them on FFPE tissue and 27% on cytology slides. But you can see, as I just mentioned, like 29% of the in-house case, we actually use the cytology slides, meaning like initially we will probably only success for only like 70% of the time using the tissue, FFPE tissue. But we actually can rescue another 30% of the patients by utilizing the cytology slides because they are just looks much better than the FFPE. Next slide. And we head-to-head compare the test result for FFPE tissue and cytology slides. We found the successful rate is equivalent between the FFPE tissue and the cytology smear. So keep in mind, when we use the cytology slides, means the FFPE tissue is pretty inadequate or borderline. That's the time we switch to do the cytology slides. So the numbers on the cytology slides are actually coming from those more challenging cases. So even in those more challenging cases, we found a successful rate that on the left is a complete successful rate, means both the DNA and RNA component both success. It's equivalent about for the cytology smears compared to the FFPE. And there's a low rate of fail in one of the panel, RNA a little bit more than DNA, which means even in those challenging cases, the cytology, the case we run the cytology slides actually have a pretty decent successful rate compared to the FFPE tissue. Next slide. And we compare the result of what actually the alterations we found between the FFPE specimen and cytology. Of note, this is not a head-to-head comparison of the same case we do both tests. It's over those like about 1,000 cases, we look at the performance of the FFPE tissue and the cytology specimen. On the table on the right, you can see the FFPE found about 74% of them have an alteration in a small nucleotide variant or indels they can found in FFPE tissue. In cytology, actually 81% of the case found those like small variant, small single nucleotide variant or small indels. For fusions, either of them about like 13 to 12% of them found fusions. For splice variants, especially the MEG exon 14 skippings, there's like about 13 to 7% of them got found in either FFPE or cytology specimen. So this table showed us that cytology specimen actually found very similar prevalence of those alterations compared to FFPE tissue. This reassure us that if we run the cytology specimen, we can find exactly the same alterations that have FDA approved the therapy in lung cancers, which is giving us really good confidence that we have good successful rate, but also reliable result of finding those important targets. So on the left, we can see that nearly all primary lung cancer samples have clinical significant alterations observed in about equal number among FFPE tissue and cytology specimens. So those suggest that cytology specimen have equivalent performance compared to FFPE tissue to do the comprehensive genomic profiling. That's why our data show that routine cytology slides should be considered as a resource to test when FPE tissue is insufficient or unavailable. Next slide. So again, we will share some more of the Mayo Clinic experience. Let's look at some of our quotes from our clinicians. So this is a quote from Dr. Adele, who is a consultant at Mayo Clinic, who is an interventional pulmonologist. So he actually performed a lot of those bronchoscope. So we know when the bronchoscopist, the pulmonologists, they do bronchoscopy. Many times they take a biopsy, and we have cytotechnologists on site to do the Rose evaluation. And many times they do the evaluation, we make the diagnosis, and at the end, it can be enough or not enough material. On the pathologist side, we always say, hey, we need more material, we need more material. And the pulmonologist says, how much do you need? I already give you a lot. But the pathologist say, hey, what we got is only blood. So there's like nothing we can actually do any testing. So many times there's a lot of communications, or sometimes like frustrations between pathologists and pulmonologists, like how much you need, right? But let's see the quote from our pulmonologist. Oh, please go back to the previous slide. So he said, at Mayo Clinic, the proceduralist who perform FMA guarded against molecular inadequacy by retrieving additional specimen when possible to add to the cell block container. Let's see what Katie's interpretation of this quote. Next slide.
Thanks, Dr. Lowe. So as Dr. Lowe said, we do at Mayo do rapid on-site evaluations. We actually have cytotechs going on to these procedures. They collect the cytology specimens. They will be using the needles to spread the contents on the slides. We usually smear them. We'll actually have one spray fixed for later staining with the Papa Nicolau stain while we do a right Giemsa stain on the air-dried specimen. We're able to use that slide to help with diagnostic adequacy, in that we can give the procedurist that direct response about whether or not we have enough material, or if we need more passes. They also take that needle and rinse it with saline into a container that we can bring back to the lab to produce a cell block from. And that cell block allows us to do some ancillary immunohistochemistry and molecular studies. Next slide, please. You're on mute again, Dr. Lowe.
Okay, I got too excited. So, so we know, like traditionally, cytotechs, when they go on-site evaluation, they were taught not to make the diagnosis, not to tell there's a tumor or not, and they always just say there is sufficient or insufficient diagnostic material. That's traditionally the cytotech were trained. But in our institutions, we want to give the cytotechs more leverage to let the the pulmonologists know that do you have sufficient material for not only diagnosis, but also for molecular testing. Because that's kind of like an elephant in the room. Like the pulmonologists, many times they know that's more likely it's cancer. The cytotech actually look at the slide, they found, yeah, that's cancer. But instead of just stop and say, yeah, that's sufficient material for diagnosis, we want the cytotechs to feedback to the pulmonologist, say, hey, we need more material actually because very likely we need molecular testing down the road. So they can take more at that time to make sure we not only have the diagnostic material, but also have sufficient material for molecular testing. And we see another quote here that's from Dr. Graham, who is a pathologist. And because not all the procedures are done by endoscope or those minimally invasive, many times those are done by interventional radiologists who perform a percutaneous biopsy for a lesion, likely like a more peripheral lung cancer lesion. So our pathologists and many of the Mayo Clinic interventional radiologists who perform aspirations, do an extra slight touch preparation. Let's see how Katie's interpretation of this quote.
Next slide, please. Thank you. So we do have our cytotechs going on to these procedures. They are looking at these specimens and giving diagnostic adequacy feedback, as well as we have them trained for molecular adequacy. They are given guidelines for the different testing requirements, how many cells we are needing for the different molecular tests that we might be performing on the specimen. And so they are able to give that feedback right to the procedurist to say, I need more slides, or please collect a couple extra passes so we can put it into cell block for more workup. And hopefully this, kind of builds that camaraderie and that we're all kind of doing what we can to produce the best testing options for the patient. Next slide, please. We do think that this promotes a lot of efficient teamwork procedures and workflows. We're able to have communication between the procedurist and the cytotechnologist and the cytopathologist in order to basically get the most kind of bang for our buck on the material that we have. If we have a cell block made, our cytopathologists can ask for more cuts up front. If they know that they're going to need more testing to help with the actual tumor workup, they will actually go and say, I need upfront this many unstained slides so that we don't have to go back to the block more than necessary upfront. Next slide.
Yeah, thank you, Katie. So as a molecular pathologist, we know in our lab we have really good assays. But we also know that whatever good assays you have, if you don't have sufficient material, your assay just doesn't able to work. So a lot of those pre-analytical considerations are very important. As Katie illustrate, like during proceduralists, they do the procedure. If they can get more material up front, that's a huge help that we can get more instead of have to go back to the patient to get more material. If we can get it up front, that's the best first. And then when we have an order submitted by our clinician, they want to do molecular testing, especially large panel testing, we review the whole set of material. As I say, if it's a in-house case, if it's a cytology case, we pull all the biopsy, we pull the cell, the tissue block, we pull the cell block, we pull all the stained and unstained slide in the smears. We evaluate the whole case and decide what's the best material. So instead of the traditional best block concept, we're actually thinking about the best material. That's why when a referring institution sends a case to Mayo Clinic Laboratory for testing, we also encourage the referring institution to send the whole case to us. Because traditionally we just receive the best block, but the block may not have much tissue left. But if the smear actually helps much, so we actually request the whole, encourage the whole case to be sent to us. We have cytotechs and pathologists to review the whole case and decide what's the most likely successful specimen to go forward for the testing. And all the unused material we will send back to the referring institution. We are not like keeping those because we would like those material to go back to the referring institutions and only use the best material to test and give the patient the best likelihood to success the molecular testing. Next slide. And we know that traditionally we think those cytology smears are diagnostic material. They are kind of like legally bounded because they are diagnostic material and there are evidence there. Traditionally, we are reluctant to use them because when we use the cytology specimen, we actually dissolve every cells on the slide and then we test them and the slide is used. So it's like no longer be able to come back. Not like the cell block, we cut into the block or the tissue block, we still have the diagnostic material left. So initially, many people have some concern of if we use them, then we don't get them back anymore. Then I don't have any material, any evidence left. But nowadays, we know like digital scanning become very, very quick and much lower price to do those digital scanning. So in our laboratory, if we utilize a cytology smear for molecular testing, we digitally scan the slide. So we have a digital copy of the slide that we use. So so that's why after we use the slide, we still have a digital copy of that. So we feel like no afraid of utilizing those smears because we still have a copy of that. So that's why. So we can mitigate the loss of specimen due to cytology testing. We use the digital staining for all the cytology smears before performing the molecular testing. I think that's the last slide. So we save good amount of time for question and answers. So if anyone have any questions, we are happy to discuss about them.
Thank you so much, Dr. Lowe and Katie. At this time, we'd like to take any questions that you in the audience may have. Again, please submit your questions through the Q&A icon in Zoom. And I did see, I believe that we had one already. If we could go ahead and pull that up. Not sure if somebody wants to share their screens, but everybody can see the questions. If not, I can just read. We have a couple already. I'll go ahead and read. First question submitted from the audience was, are there any unique quality metrics for NGS results from cytology specimens versus FFPE?
So I can start with this one. So we don't really use any unique quality metrics between the cytology specimen versus FFPE. So either specimen will go to the lab and do DNA and RNA extraction, depends on the assay. Well, MCSTB is an assay that have both DNA and RNA component. We use standard extractions, and then we go through the library prep and actually the sequencing. So all the metrics are still the same, and we evaluate the same metrics. As long as they can pass those metrics, they go ahead to the next steps. But on the research side, we actually found that the FFPE specimens, because they are formalin fixed, so the DNA RNA are more fragmented. But for smears, those DNA RNA are less fragmented, so their length is longer and bigger. So in general, the quality is better in the cytology smears. But for quality metrics per se, there's no difference after we went through the DNA RNA extraction procedure.
Thanks, Dr. Lowe. The next question is, how is cytology material dissected off of the slide?
Yeah. Katie, do you want to take this or I?
I mean, they're scraping the whole slide. So they're actually we take the cover slip off, we soak it in xylene to get off any mounting media. And then when it gets down to the molecular lab, they're actually scraping all of the material off and into a vial to run.
Yeah, so pretty much we were not able to circle the cells on the slide, kind of like the FFPE. We are able to circle where the tumor is. For the cytology specimen, the whole slide is scraped and dissolved into the solution and go through the next step, DNA RNA extraction. So we do really care for evaluate the percentage of tumor cells on the smear, because we know that we tend to see the tumor cells, but many times there will be a lot of background lymphocytes, especially in a lymph node FNA specimens. So we do evaluate how much the tumor percentage, and we make sure it's above the threshold, the acceptance threshold before we go ahead to do the scraping because we know we are not able to circle them. Yeah.
Thank you. Next question is, digital scanning of cytology smears is challenging because of the 3D nature of smears. Does Mayo have a digital scanning approach to mitigate this?
Yeah, that's a good question. So like cytology specimen, because they are they are whole cells, so the plane is there's a multiple planes of that. So like traditionally for diagnostic purposes, cytology is kind of always the last one to adopt the digital scanning and those like digital sign out because of the Z-stack issue. That's exactly the question that we encountered every day. So we do actually evaluate different scanners in our laboratories. So initially we use a version of scanner, but soon when we found a better scanner that can do better the Z-stacking, we change to the different scanner. So of course we validate the imaging quality is legit, but we always improve our scanning procedure to use better scanners to better preserve the 3D slash the Z stacking of the diagnostic material.
Wonderful. All right. Next question is, what methodology do you use to make cell blocks to mitigate for pre-analytical variables?
Sorry, can you reread that?
What methodology do you use to make cell blocks in order to mitigate for pre-analytical variables?
That is actually a really good question that I do not necessarily know the whole answer to. But for our purposes, we do use the clot method. The Thambren occasionally, but we've actually gone to a different method that I don't have in front of me right now. Sorry, I can't answer that.
Yeah, we understand that cytology preparation can be tricky between different labs because of the different preparation of them. So it's a hard question for individual labs to validate like all the cytology specimen from all the institutions to be able to accept. So we admit that that's a real world challenging. So we try our best to validate as many preparation as possible, at least the preparations we use in our institution. So we feel very comfortable use the in-house material. But for referring institutions, we try our best to validate those during our validation process. And if we notice something unusual, we will flag those like if like a specific institution's specimen have much higher or lower percentage of finding or failure rate or something. We keep an eye on those to avoid any false positive, false negative, or higher failure rate. But you are right. Like many of the cytology preparations can be tricky.
Absolutely. So the next question is actually more of a shout out or a statement. It says, not a question, more of a comment, but Mayo cytotechnologists are the best. And I think everybody on this team at least would agree with that statement. I'm not biased or anything. After that, the next question is, I've encountered many accounts in Asia who don't perform rapid evaluations. I was wondering how to encourage such accounts to perform cytology smears.
I mean, we know a lot of institutions don't perform ROSE procedures, and all I can say is they do have a harder time of getting adequate material for diagnostic purposes as well as molecular testing. I mean, I'm a cytotech, so I mean, I feel like I think we're pretty valuable. But I do think that, to say that we bring a lot to the table, that we can really give a lot of feedback and a lot of help in the procedure room. I can't stress that enough. We have found that, when we do go on procedures, the success rate has gone up a lot. And I know that, not everybody has that capability, but, if they can implement, the cytotechs, we are a great resource.
Yeah, exactly. In different settings, we know sometimes it's difficult because a hospital may have many satellite sites. So it's hard to staff all the procedure room with cytotechs to like do rows evaluations. But with more technology now do those like remote evaluations, some of those can be solved like partially. But again, I totally agree with Katie that roles is very important in the current practice, not only for the diagnostic purposes, but also for the downstream molecular testing, because now it's a standard care. I often, when I talk about this, I always say, well, if we do an inadequate biopsy that is a non-diagnostic, or it's diagnostic, but we cannot complete the molecular workup, then it's an incomplete procedure. So then why do things like incomplete or failure schedule procedure rather than actually just do it once and success upfront? So those actually save a lot of the money and financially for the institution to bring back the patient to do another biopsy. But also most important is for patient care, right? The patient doesn't need to go through another procedure, which put the patient on another risk of those, although minimally invasive, but still an invasive procedure. So both financially and patient care wise. And also important is turnaround time. To able to do it the success the first time around is much better than to repeat and arrange another biopsy. So many of those advantage I think are worth encourage them. And that's also why we use the cytology specimen if we think the FFPE specimen is not good for molecular testing, because we could still do the FFPE and fail. But then we retest them, and that's like another like couple of weeks. But if we can success the first time to get the cytology smear to work, we would go ahead to do that to much likely get the first time success, much better for turnaround time and patient care to get the proper treatment the patient need.
Yeah, to that end, there's another statement or shout out in the Q&A. Agree, cytologists are valuable and facilitate the diagnosis and management of our patients. So
exactly.
Hats off to the cytotech team. Next question is, do your cytotechs or pathologists perform rows at your facility?
Cytotechs, our cytotechs are the ones who are going on the procedures, but we do have the capability of doing cytopathology or telepathology if we need to. Sometimes the procedurists are also there to hopefully treat at the same time. Cytotechs are not supposed to give, diagnoses. So we do have that capability of, if we need to phone a friend, aka a cytopathologist, we do have that option. We don't do it on all of our procedures, but it is something that we can do if we need to.
Thank you, Katie. I'm not seeing any additional questions in the Q&A section. There were a few pre-submitted questions, though, that if you wouldn't mind, I'd like to run through with you both. I know
Sure.
you both had addressed this in the presentation itself with that beautiful overview of fixatives, but is there anything else you would like the audience to know regarding alcohol-based fixatives, different fixatives and stain types, and what they might mean for like DNA versus RNA, for instance?
We do have a lot of success with alcohol-based fixatives. We're validated for multiple different fixatives, like Cytolite and Cytorich Red, I think, has been validated as well. And the only thing that we, have issues with in general are decal, but that's tissue. So for our cytology, we've had a lot of success in just all of the alcohol-based fixatives for both DNA and RNA. I believe when they first started the testing, they were actually having issues with the RNA and DNA concentrations being too high, that they would kind of potentially, flow over. And so, we do see a lot of success with those.
Thank you, Katie. Next question in the chat, or sorry, in the Q&A module is, will we have access to the PowerPoint slides? The answer to that is yes, and I'll go through that in a second. But we're getting back to the pre-submitted questions. There was one more that I wanted to run by you both, and that was how to best guarantee enough tumor DNA for NGS during rows. Are there any suggestions or ideas you have to that end?
So we actually, for training our cytotechs to kind of give that feedback, we are looking for number of tumor cells as well as percent. There are some things that you can't help with, tumor percent being, if it's in a lymph node, you have a lot of lymphocytes. But generally speaking, if we can get enough cells on the slides, and this isn't just like one slide, it can be over multiple slides. It is a cumulative. We generally say if we can get at least 3,000 for DNA and at least 1,500 for RNA, I mean, that's bare minimum. We can at least try and run our MCSTP testing on that smear. So generally speaking, I think our preferred is 10,000 tumor cells. But we do have a little bit of wiggle room as far as how low we can go if we have to. But the most success is going to be to have, more cells, at least 20% tumor on those smears.
Thank you, Katie. Oftentimes folks will follow up with, well, how low are you willing to go, or will you still attempt?
That is the lowest we'll go. And that's
right.
even like,
Thank you for clarifying that. All right. I am not seeing any additional questions. So with that, I just want to thank everyone for participating in today's Present Approaches to Testing webinar on cytology specimen utilization, a proven approach to genetic sequencing. If you have a question that wasn't addressed during today's session, or if you have any additional questions, please include them in your evaluation. There is a link in the chat that has been provided for you to access this evaluation. Reminder, laboratory credit is extended for this program. So upon finalizing your evaluation, you'll have the option to claim credit and print your certificate. If you registered for this webinar and joined by phone only, please email us at mcleducation@mayo.edu if you do not receive the evaluation. And as a final reminder, this program was recorded and will be archived on our website in a few weeks. And again, a PDF of the slides will be provided as well. Thank you again, everyone, for joining us, and have a great day.
Thank you.
Thank you.
Thank you for participating. Please click the button below to complete the evaluation and obtain credit.